That's the maximum that I can enlarge it. Hopefully you can see it. All right, yes. So that meaning around 100. Okay, who can tell me how we can calculate, let's see, the heart rate? Okay, anybody? Or I can, let's see, pick
300
some.
rules.
Okay, 300 divided by the
big
3.
squares.
The number of the big squares. If you look at here, we do have, let's see, because that's rhythmic. First of all, we have to have a rhythmic heartbeats. If you do have a rhythmic heartbeats, we can calculate easily if we divide 300 by the number of these big squares. So here we do have roughly about 3 big squares between the two airways, and that represents about 100. 300 divided by 3, that means 100. There is another way to calculate it that's very similar to the how you count the pulse rate of the patient. What do you usually you do? You count the beats in a certain time interval. For example, for counting for 30 seconds or maybe 15 seconds. But we don't have these long intervals. This is why we have only 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds. So we can count till 5 seconds. And if we count how many R we do have within 5 seconds, we have to multiply by, who can tell me? I cannot hear you.
12.
12, exactly, because you are interested in the 60 in 1 minute. And exactly the 5 seconds is 12 times, exactly less than 60 seconds. So let's do the same. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 times 12. That makes around 108. So a little bit more than 100, but it's close to 100. Very good. Can you see the strip, the ECG strip, and whatever the answers?
Yes.
Good.
Yes,
All right.
okay.
All right, because I do have a very wide screen, so this is what I have no idea what can you see from this one. Okay, let's see. The ECGs was the first one. Good. Now let's see the other one. Determine the, all right. Okay. No, I cannot enlarge more. Great, very good. Okay, but only 3 answers I got, not too many. Now, who can tell me how can we calculate the axis, okay? No? Odysseus?
We have to find the one that is more positive.
Let's see, equiphasic. Equiphasic.
Sorry, the equiphasic, sorry.
Equiphasic, that meaning the positivity and negativity is about the same.
AVF. Yeah, which is the AVF.
Okay, AVF, all right. And it has to be perpendicular to
to the
AVF.
axis. Yeah.
Okay, AVF looking at exactly the bottom, the diaphragm, which means 90 degrees. So the axis can be 0 or 180. Which lead that you should look at? Lead number 1. If lead number 1 positive, 0. If lead number 1 negative, 180. Okay, everybody understood this?
Yes, but should we memorize that, like, for example, without the circle, without the 360 degrees, should we, I don't know, memorize that when we look at the AVF, afterwards we look at the first one? And
well,
like,
only one thing that you should memorize, the degrees of these leads. Because, so you should memorize that lead number 1 is 0, lead number 2 is 60, lead number 3 is 120, AVR is How much is AVR?
Minus
210,
okay.
yes, and AVL minus 30, and AVF is 90. This is what you should memorize. And roughly, that's another possibility that you can do. Choose the biggest R wave. Choose the biggest one. Which is the biggest? And lead number 1 is the biggest one, and after lead number 2. So that meaning we are parallel with lead number 1. So this is why we can say that this is roughly about, let's see, 0. Another one, the quadratic approach, if you watch the video, only what you have to do, look at first lead number 1 and AVF. If both positive, you are in a normal range. No problem, no doubt. You don't need to do anything else. And after you can choose which is the biggest one. That's fine. Or if lead number 1 is positive, however, lead number AVF is negative, you are in the upper quadrant. I will show to you this one and we can go through this all. So that's meaning we have pathological left deviation or only left deviation. And if lead number 1 is negative, immediately you can say that's a right deviation. That's it. So relatively, this axis is very easy to diagnose. And what are we going to use this axis for? Making diagnosis, because a lot of disease is associated with an abnormal axis deviation. We are not interested in those situations when the anatomical axis is about the same as an electrical axis. We are interested in when they are not. So when you cannot explain the axis deviation by anatomical situation. For example, if somebody is obese one, an elderly one, the axis usually is around 0. So it's a horizontal axis. So that's fine. It can be minus 10. Yeah, it's completely normal. However, if you have a young person, for example, usually the axis is close to 90. So it's a skinny one, tall one, mostly 90. However, if you do see a very obese one and the elderly one, and the axis is around 90 or 100, that can be an abnormal sign, and you can say that possible something else caused. Right ventricular hypertrophy, or maybe posterior hemiblock, another that we are going to study later on, that can alter the axis. Okay, let's move on. If you do have any question, you can write, you can raise your hand, or you can speak out if you wish. Okay, now let's see. Wow, now, for sure this everybody will do it. No, what is this? What is this? What is this? The question was, which part, the calcium efflux? It's in the plateau phase. This is an active contraction. Wow, not the first one. What's happening in the first phase?
Sodium ions.
Exactly, the sodium ion. And in the first and the second, yeah, we do have the potassium as well, the fast current potassium level, but the calcium, mainly the calcium comes in, all right. But basically, nobody's going to ask you when you're looking at an ECG. Okay, let's see the next one. Oh, average heart rate. So possible this is not rhythmic. Yeah. Okay, that's good. How did we do that? Very similarly. 1 second, 2 seconds, 3 seconds. You can use the 3 seconds. It's okay because this you have to multiply by 20. 1, 2, 3, 4, 5 is around 100. Or if you go a little bit further, 1, 2, 3, 4, 5, 6. We do have 4, so we have to multiply by 15. So 2, 4, 6. So it means around 90. All right. So this is how we can calculate it. Good. So if you calculate with a longer interval, your, let's see, rate be more accurate one. If you calculate shorter one, relatively you make a bigger mistake. But basically because the normal heart rate is between 60 and 100, doesn't matter. Okay, good. No, again, a main electrical axis. Okay, good. Very good. Basically, the others can join to the Kahoot if they are logging into the kahoot.it. You can see here, and that's the pin is 7294863. We do not have too many Kahoots question about this one, but if they wish, they can, let's see, join it. Now let's see. Axis. We can go for the equiphasic lead. Which is equiphasic lead?
AVR.
Okay, Mate, or who was it for the last one?
Both. Me and Mate.
Okay, let's have somebody else. Okay, somebody else, because both of you are talking. Okay, Elad. Are you here?
Yes, I'm here.
Good. Now let's say equiphasic. Which is the most equiphasic one?
I guess AVR.
Good, very good. So it meaning that we are going to be perpendicular to AVR. That means AVR is located is 210. Okay.
Yes.
Which angle is perpendicular to 210?
To 110?
Yes, because AVR is 210.
30?
Which
No.
one? No.
No, 30.
210 minus 90 makes?
210. Yeah, so 20, I guess.
120, this is one. And another side, a little bit difficult one to see, because 210 up to 270, we do have 60 degrees when we are reaching the minus 90. And another 30 degrees makes it 90. So minus 60 and 120. All right?
Yes.
I will show you the x-axis system and you will understand. Okay, so this is located, or let's see, on the right side as 120. But it cannot be on the left side because lead number 1 is negative. So it has to be on the right side. So that's 120. So we do have a pathological right deviation. Okay, good. All right. Next. Wow, again. Uh-oh. All right, let's see. Now, okay, let's look at who is going to present it. Biniam? Biniam
Yes.
is not. Okay, please.
I'm present. Okay, I'm not completely sure because I came a bit late as well. But I mean, I can't find any equiphasic leads, but
mostly equiphasic. It doesn't mean that you have to be exactly what we are saying.
From the limb leads.
I'm sorry. Wait a minute. Okay, good. And now Mike. Okay. Now, which is the most equiphasic one?
The lead 2.
Okay, lead 2. And you can make that's a little bit more positive than negative. Yeah. Yes? Okay, yes. That's great. So you are perpendicular to lead number 2. Okay. So what does it mean? Lead number 2 is looking at 60. Yes?
Yeah. Yes.
Okay. 90 minus 90 makes minus 30. Plus
Yeah.
90 makes 150. Which one?
I'm not completely sure.
You have to look at lead number 1.
Yeah.
You are on the left side or right side? That's the left side, so that's minus 30.
But wasn't the answer minus 20, a left-sided deviation?
Okay, okay, very good, very good, very good. But why did we say minus 20? Because lead number 3 is not equiphasic, it's more positive.
Yeah.
This is why is relatively closer to 0. That if you want to estimate, usually you can use 10 degrees plus or minus. So that means you are subtracting 10 degrees. So this is why it's minus 20. Okay?
Okay.
Don't worry, because we will have zillions of, let's see, this kind of axis evaluation. Okay, congratulations. Okay, so these are the winner. Let's see, Monovalent and NK and Mate. All right, good. Now I'm not going to close all of it. I'm going to close this one. I don't need that one. Okay. Wait a minute, somebody. Okay, I think he hasn't joined yet because he's not listed. Okay, I'm sending you this link over here, email link. Okay, now let's see and let's go for the today's material. But before we go there, let's revise a little bit this axis. Okay, let's understand the axis. I do have a presentation that's already made a video on it, but I'm going to open, let's say, a PowerPoint presentation, and I'm going to go step by step. Okay, this is the ready. Okay, chat, somebody written that in the chat. I could join now through the second. Thank you. Okay, that's great. Okay. Now, okay, so that means the English version. Of course, we like the English version. However, you know Hungarian very much, okay?
Yeah, sure.
And you have to take the exam and final exam. Heart rate, I'm not going to go through the heart rate because you know these rules. Okay, let's go and let's see this kind of approaches when the equiphasic approach about the axis. Okay, let's choose somebody, okay. Who couldn't, okay, so let's go back to Biniam, okay, because you were not for sure that what was the answer. Biniam?
Yes, true.
Okay, so let's see. Which is the equiphasic lead? Most equiphasic one?
AVF, I mean.
Okay, AV.
F, isn't
it? AV.
F.
F, exactly. AVF is equiphasic one. Okay, good. So we are going for AVF, okay. And when we go for AVF, that's an equiphasic one, okay. Next one, what does it mean? AVF is located at 90 degrees, yes? So we have to be perpendicular to AVF. There are two ways. If you subtract 90 degrees or you add 90 degrees, so the axis can be located at 0 or 180. So let's move back to the ECG, because how can we see whether this is on lead number 1 or exactly the opposite? Because the electrical impulse or the potential difference is the biggest one when we are parallel with the axis. So we do have the highest positivity if we do have parallel with lead number 1. If it's opposite, the biggest negativity, okay? Let's go back. Let's look at lead number 1. Is it positive?
Yeah, there's a positive.
Go back. Okay, go back. So which one?
I didn't hear one. Oh yeah, I didn't hear for some reason. Okay.
All right, so this is how we can estimate or calculate the axis. This is the equivalent. Let's look at this one. Who wants to present it? Let's Alex.
Yes. Okay. Where are we?
Yeah, we are here.
2, it looks mostly equiphasic to me.
Okay.
Positive though.
Which one?
2. Lead
Lead
number
number
2.
2. Okay, lead number 2 is a mostly equiphasic. Okay, let's go back. All right, let's go back here. So that's meaning we are equiphasic to lead number 2. All right, so 90, 90 minus 30 or minus or plus 150. Which lead that you would look at?
AVL, right?
AVL. Okay, look at AVL.
AVL very
is
positive.
Okay, so it meaning that
That
the
means
axis
minus 30.
exactly and exactly close to minus 30. Okay,
And
good.
this be close to minus 20 since the lead number 2 is a bit positive.
Yes, but this is not exactly minus 30. This is what we had, a little bit less. So this was 120. Yes, that's great. That's great. Now, that other approach that's called a quadratic approach. If you use only 2 leads, you can see which quadrant we are. If you look at lead number 1 is positive on the, as you see here, on the left side, and negative on the right side. Okay, AVF is positive between 0 and 180, so done in the, let's see, below this a half, and negative above. So if you summarize and if you go back, if lead number 1 is positive, we are on the left side. However, if AVF is positive, that's a normal. If AVF negative, we are here. So that means left axis deviation. If lead number 1 negative, we are on the right side. AVF is positive, that's a right axis deviation. And usually here, it's very rare that we do have any kind of axes in sometimes the supraventricular tachycardias that can cause. Usually we are not counting on that quadrant. Now let's see, for example, the normal axis. What did I say? Normal axis, when we do have lead number 1 positive and AVF positive. Let's look at lead number 1 is positive, so we are on the left side. AVF is positive, but both should be true, so it's meaning only this area is positive. So you have to look at first 1, AVF, both positive, exactly, you can say normal. Okay, let's see the extreme left deviation. Extreme left deviation, we are on the left side, okay? So lead number 1 should be positive, yes? Okay, AVF is negative, so we are up here. Okay, so that meaning the common part is exactly this quadrant, this left quadrant. And look at lead number 2, negativity. If it's lead number 2 is negative, only the common part of it. So that means that we do have between minus 30 and minus 90, and that means extreme left deviation. So extreme left deviation means that for sure that's pathological. There is no way that any kind of anatomical situation can explain this kind of deviation. All right?
Yes, but a question, why taking the lead number 2 after the AVF and the lead number 1?
Okay, because if you take only lead number 1 and AVF, you have only this quadrant. And this quadrant, if you can remember, we do divide this quadrant between 2 parts. This part between 0 and minus 30, that meant left deviation. Minus 30, minus 90, extreme left deviation, or you can say that that's a pathological deviation. Pathological deviation means that there is no way that anatomical situation can explain this deviation. So this is for sure pathological one. However, if the axis is falling in this area, there is an anatomic situation when you can fall in these little areas. So that can be normal, but can be abnormal as well. Okay? This is why you should specify. Of course, if you look at only the tracing, there is no way that you can tell that this area is pathological or not. But if you are looking at the patient and skinny one and young one and tall one, for sure it cannot fall in this area. Okay? It could be some kind of abnormality. Clear?
Yes, but why lead number 2?
Well, because if you want to cut this quarter, and especially you want to cut at -30, lead number 2 exactly perpendicular to AVL. So lead number 2 is changing the positivity and negativity at -30. This area is negative, this area is positive.
Okay, thank you.
All right, and this way you are choosing the negative part. And the common part, when you do have one positive, AVF negative, lead number 2 is negative, only this part. However, if you want to know whether you are here or not, what should be the lead number 2? If you want to see whether it is falling here.
Has to be positive.
Positive, exactly. So 1 positive AVF negative and 2 positive, we are between 0 and -30. Good, very good. Okay. Extreme right deviation, lead number 1 is negative, AVF is positive. Okay, that's a common part. If you want to be sure that that's for sure, because pathological right deviation means 100 and over. Only one lead, only wait a minute, go back, okay? If you look at, for example, AVR is perpendicular 120. And if you do have perpendicular in AVR or positive AVR, for sure that's an extreme right deviation. But if you do have one negativity, you can see immediately that's a right deviation, extreme right deviation. So there's no problem with that.
Excuse me, doctor.
Yes?
You mentioned that extreme right deviation is from 100, negative,
yes.
positive 100. But in the videos, I think you said 110.
Okay, 110 and 100, that's fine. 100,
So
let's be 110, okay? The video is good.
Okay.
So it doesn't matter. Believe me, this 10 degrees means nothing.
Okay.
Okay. Now, this is what we said before. That's a left deviation. Okay. And lead number 2 is positive. So this area is that one. Okay. All right. Now, let's see this one first. Who is going to present this one? That's a Bo Young.
Hello. I'm here.
Yes.
Yeah. Yes. I think the most equivalent one is AVR.
Okay, the most equivalent one is AVR. That's fine. That's AVR because AVL is more negative.
Or maybe lead 2.
Lead number 2. Okay, let's
sure.
make it lead number 2. That's okay. AVR is the same and lead number 2 about the same. Okay, I accept it both.
Yeah.
Let's see.
Okay.
Let's see. Okay.
Yes.
So, but the quadratic approach is not the equiphasic one.
Right. Quadratic approach.
Yes, this means lead number 1 is
negative.
Negative. AVF is
positive.
So this is why we have a right deviation. If you do say that's a pathological right deviation, that's okay.
Right.
Okay, good. All right, let's see the next one. Okay. All right, and Fadl.
Yes, I'm here.
Okay.
Okay, so lead 1 is positive, and then AVF is negative. So that would be a left axis deviation.
Yes, and when we discuss lead number 2 is positive, so that's a left deviation and non-pathological left deviation. Good, very good, very good. Okay, let's look at this one. I cannot pronounce this one. This Gichon. How do you pronounce your name?
It was correct, Kihan, yes.
Most correct, okay, thank you. Okay, now let's see this.
So the the first lead is positive.
Okay, the first lead is positive. Okay, so we are on the left side. AVF is?
It's negative.
Negative. Okay, so we do have a
look
left
at the,
deviation.
And we need to look at the second lead, and it's negative, so it's the extreme left deviation.
Good. Very, very good. Very good. Very good. Okay. Now, I think if you watch again, let's see the videos, you will understand easily how you can estimate the axis for sure and other things. Now, let's go and let's start and discuss what we do have for today. And this is the impulse formation abnormalities. Now, what does it mean? Now, that's a major category when we do have, it's called arrhythmias. Arrhythmias, what do you think? What is arrhythmias? Now let's see who is going to answer me this one. George?
Yes, doctor. Well, arrhythmia literally means abnormal rhythm of the heart.
Okay, so it's meaning that you are talking about how the RR intervals are coming. Yes?
Mm-hmm.
So whether they are coming in a regular interval or not. This is one thing. So when we talk about rhythm, we are talking about one thing. One, that's the RR interval are the same. This is one thing. What else? For example, if you do, what is a normal rhythm? What is a normal heart rate?
65 to 70 beats per minute.
Okay, 60 to 100. This is what we said, 60 to 100. Okay, if we have more than 100, that means tachycardia. If we do have less than 60, that's a bradycardia. These are not rhythmic. We say that's a rhythmic, but it's not normal rhythm. This is why we say that the rate is important to determine the rhythm. Another thing, normally, what's going to generate the impulse? George?
The SA node.
SA node. So we have to have a sinus rhythm that that impulse coming from the sinus, and this is how we have a sinus rhythm. So basically, we're talking about arrhythmia when we don't have a normal sinus rhythm. Okay? If you don't have a normal sinus rhythm, that's fine. Now, that's arrhythmia can be caused by impulse formation abnormality. It's meaning that the impulse is not formed regularly in the sinus, or it's not formed by the sinus. That means an impulse formation abnormality. Okay, the impulse can generate it not only by the sinus, but can be originated from the AV or can be originated from ventricle. These are arrhythmias. Okay. So today we are going to discuss the impulse formation abnormality. However, there is another possibility that we do have arrhythmias when we do have a normally formed impulse in the sinus. However, this impulse is not propagated to the ventricle. Somehow we do have a conduction block. So arrhythmia can be due to block, conduction abnormality. So today we are going to discuss the impulse formation abnormality, and then next we are going to discuss the conduction abnormality. Now let's see. This is what we said. What is arrhythmia? That is not a normal sinus rhythm. That's it. Okay, this is what I explained you very nicely. Okay, now another thing. An arrhythmia can be a single aberrant beat. Okay, but another thing that can be somehow a sustained arrhythmias. For example, when we do have a completely arrest, sinus arrest, or when we do have a junctional, or when we do have an abnormal sinus or atrial impulse formation. So somehow this arrhythmia can be completely unseen or unsensed, so nobody can sense it. That's completely normal, but can be life-threatening situation as well. Now, let's see, this is what we're meaning that, for example, low heart rate can be seen in athletes, that can be normal. However, if somebody has, for example, increased intracranial pressure, that can be a clinical sign as well. Okay, what can be there? This is what I mentioned. Usually, patient cannot notice anything, but sometimes if you do have a irregular beats, that can be sensed and palpitation. The patient is going to be sense fatigue, because if the cardiac output is altered by these arrhythmias as well, or dizziness, light headache, disorientation, or very much problem can occur, for example, in heart failure or circulatory collapse, or death can be due to arrhythmias as well. Can somebody tell me which kind of arrhythmia can kill the patient immediately? What kind of rhythm? Lydia? Possibly she, but she is not here. No. Okay. Yeah, the Mickey. Mickey is here. Mickey? No, not. Okay. Who had Nicolette?
Hello.
Hi, Mickey. You are Mickey? Yes.
Yeah, that's me.
Okay, Mickey. Looks like my nickname is Mickey as well.
Oh, yeah. Hi.
Okay. Now, what kind of arrhythmia can kill the patient immediately? Anybody can help her?
What?
Yeah.
The ventricular?
Ventricular? Yes. Ventricular fibrillation.
Fibrillation,
yes.
yeah.
That can kill the patient immediately, because in that situation, the cardiac output is zero. There is no circulation. Okay, very good. All right, very good. Now, what can cause arrhythmias? Relatively, a lot of things can cause arrhythmias. First of all, the sympathetic stimulation. When we do have, let's see, nervousness or endocrine disorders or cardiac heart failure, but hypoxia, pulmonary disorder, or inflammation, drug, electrolyte, or stretching, or valvular disease. So a lot of things can cause arrhythmias. Basically, that can trigger a, let's say, a beat or an impulse, or another can blunt the normal impulse formation.
Professor?
Yes?
What about extremely cold temperatures?
Okay, that again, that can cause bradycardia, for example. That for sure is going to alter, or later on can cause ventricular fibrillation. So can kill the patient.
Okay.
This is depending on how cold that you are in. Now let's see and let's talk about the normal rhythm that I mentioned already. First of all, we have to have a constantly coming P, P, P interval. I'm saying P because we have to have a sinus impulse formation. Now, how do we know that we do have a sinus impulse formation? The sinus is located, I'm going to use this one. The sinus is located at the right atrium, all right? It's close to the vena cava. And when the impulse is formed, relatively the impulse is going to the left atrium and the right one, and goes to the AV junction and all the way to the ventricle. Now, so we do have an atrial axis, depolarization axis, that is started from the right side and goes toward the left one. So if you are looking at AVR and lead number 2. So the impulse is going toward lead number 2. Let's see what we are going to see in when we do have a atrial impulse formation. In AVR, because the impulse goes away from the AVR, this is a negative. However, because the vector, that's an atrial depolarization vector, is pointing toward lead number 2, that'd be a positive. So this is why if we do have a sinus beats, first of all, if you're looking at the ECG, you have to have a P wave, that is positive in lead number 2, negative in AVR, all right? This is what you have to see. And that P wave should be symmetric because the atrial muscle is synchronized contracted. This is what we have, a smooth, symmetric, round-shaped, all right? And the shape of the P should be identical if every bit, because they are coming from the same area, goes with the same way. So within one lead, we do have the same identical shape P waves, okay? And of course, the heart rate should be between 60 and 100. And an additional one, but that's a conduction, that every P should followed by a QRS complex. If we do not have, let's see, the P followed by QRS, that'd be arrhythmia because a conduction abnormality. But this is meaning, and the normal PR interval should be. All right. So now you know what the normal sinus rhythm is. Yes. Anybody has any question?
No, it's clear.
Okay, let's go to
sorry, doctor. So, as you said, normal sinus rhythm is going to be pretty much indicated by the relationship between AVR and lead 2, right?
No, okay. The P wave and the QRS, this is one and should be originated by the P wave. Okay, this is what we have to have. Okay.
Okay, thanks.
Now, let's look at now, how can we, let's see, evaluate the impulse formation abnormalities. Okay, we do have two different major categories of the impulse formation abnormalities. If the impulse come earlier, that is going to speed up the rate. If the impulse, that the extra impulse come later than a normal sinus beat, that's slower, and that's called passive arrhythmias. So whichever arrhythmias fasting up the average rate, that means active arrhythmias. If we do have, let's see, an other extra beat that slowing down, let's see, the heart rate, that means passive arrhythmias. Let's see which is the simplest active arrhythmia. As you see here, comes earlier, only one beat, no more, but only one beat. But because this beat came earlier, this is an active arrhythmia and usually followed by a compensatory pause. Who can tell me what kind of beat is this?
Extrasystole.
Exactly, that's an extrasystole or premature beat. That's it. Very good. Now, let's go on. So this is what we said. That's a normal situation. That's a premature beat. That's an extrasystole, what we have. And usually the RR1 is shorter than a RR and for sure is much less than RR2. Let's see another one here in this distance. This is what is called coupling interval, and that's a compensatory pause, what is following this extra beat. This is what you learn in physiology for sure. Now, what will happen when we do have a beat that came later? Not earlier, but later. So it slowed down the rate. So that means escape beat. Now, one thing that you should mention or you should remember, this escape beat coming from the lower nodal tissue. Why, as a premature beat can come from anywhere, from the muscle, from the nodal tissue, anywhere. Now, if we do have, for example, a later coming beat, and not only one beat, but we do have more than three or more than three, that's a rhythm. So usually if we do have an early coming beat that is coming at least 3 times, that's rhythm. This is what we call rhythm. All right, so 3 or more, that's rhythmic, and this is what we're talking about, the slower rate, that's an escape rhythm, and escape rhythm always coming from a nodal tissue. If not from the sinus, that has to be from the AV, or it should come from the ventricle for the Purkinje fibers. Now let's see the types of the premature beats. This is what, again, you learned, and this is repeating what you learned from physiology. This is what thing that you do have. We do have an early coming beat followed by the compensatory pause. However, as you see here, this compensatory pause is not normalizing the average rate, so the average rate be faster, and that's called uncompensated premature beat. Okay? The next one, when we do have a compensatory pause that is enough long to compensate this early coming beat, and that's the average rate, doesn't change. That means the compensated one. And we do have another one when we do have a overcompensated, when we do have a extra, let's see, length of this beat. Now, why is it important? You learn it in physiology, but I don't know whether you dedicated any kind of meaning for this undercompensated, compensated, or overcompensated beat. Now let's see who can. Nicolette, are you here?
Yeah, I'm here. Hello.
Now, what did you know about this undercompensated, compensated, or overcompensated beat? Does it mean clinically?
Honestly, not too sure.
Anybody has any kind of idea?
It affects the heart rate change?
No. Of course, it's accepting the average rate, but it has some clinical meaning because every supraventricular beat means sinus, atrial, AV. If you do have a premature beat that coming from these three areas, it should be undercompensated. If you do have a ventricular premature beat, we are going to talk about what the ventricular premature beat, as the complex is different one. This is not the same as before, it's wider and the T is inverted. So it's meaning that it should be compensated. Now, if you do have a supraventricular beat, so a sinus, atrial, or AV that is compensated or overcompensated, that's pathological, because for this compensated beat means how the muscle can recover. If you need more time for recovering, that means you do have an oxygenation abnormality of the heart. So ischemia can cause, for example, overcompensation, or in different area is compensation. So you can memorize, if we do have a supraventricular premature beat and that is compensated or overcompensated, is always pathological, so you have to search for ischemic diseases. Okay, good. Let's go on. Okay, come on. All right, now that's another possibility. See, when we do have a premature beat that exactly came between two normal R. See? Exactly in the middle. Exactly in the middle. That is called interpolated premature beat. So relatively here, the RR1 plus RR2 is equal with 2 Rs. And that's usually is a ventricle interpolated premature beat. That's, again, that's not normal, and that can represent some kind of abnormality, or maybe the let's say triggered impulse formation can occur, or ischemic changes can occur in the ventricle. Good. Let's see another one. Let's continue with this premature beat. So far we were talking about only one beat, but this beat can come regularly. For example, let's look at this one. Every second beat is a premature beat. This is a red line, indicate the premature beat. So we do have every second beat is a premature beat. That's called bigeminy. Okay, you do see that this is a short, long, short, long, short, long. Okay, that's a bigeminy. If you do have every third beat as a premature beat, that's called trigeminy, or every fourth one, that's a quadrageminy. All right, so this is what we call this allorhythm. This is not normal. It looks like rhythmic because every third one, every fourth one, every second one is a early coming beat, but this is not a rhythm for the heart. Okay. Let's see another one, is still the active arrhythmia. And now we do have, let's see, this is a time dependency. It can happen that when we do have a premature beat, there's not only one premature beat comes at the same time, but two. So it looks like we do have a, so these called couplets, okay? These called couplets. It's meaning that is a very fast triggering impulse coming, and after the normal rhythm comes back. And if it's repeatedly coming. The next one, it can be triplet or salves when we do have three fast premature beat at the same time, and that's triplets or salves. If we have more, this is rhythm. So what we have, for example, here, if we do have a more than 3 beats as an early coming beat, that's called suddenly started tachycardia because it's active, so it makes speed up the heart. So that's called paroxysmal tachycardia. What is the meaning of paroxysmal tachycardia? Start suddenly and ending suddenly. Usually a paroxysmal tachycardia is started with a premature beat and ended with another premature beat. Okay. Now the matter of the rate, we can talk about now what is not coming, let's see, fast. It's coming slowly, it's warming up, and very slowly it goes out. If it's this, let's say tachycardia is last longer than 30 seconds, this is what we call sustained tachycardia. And a paroxysmal tachycardia, the pathomechanism is the re-entry cycle. I think you heard about in physiology, yes?
Yes, sir.
Okay. However, the sustained tachycardia usually is a, let's see, an increased automacy in the different areas of the heart, and that can cause a long-lasting, let's see, tachycardia. Usually this tachycardia is not as fast as a paroxysmal tachycardia. But when we go on, as you see here, it's only the matter of the rate. We could talk about paroxysmal tachycardia or sustained tachycardia. If it's fasting up further, that means flutter. And if you do have more, that means fibrillation. When we do have fibrillation, we do have more foci that at the same time that is going to be discharged. Now, okay, I don't know whether I do have or not. Okay, let's see. I turn on my camera and try to visualize you what it means. Hopefully you can see everything. I'm going to stop the sharing and I'm going to change, let's see the view. But I think when I'm talking, you see me in the middle, yes?
Yes.
Yes, yes.
And I see myself. Okay, now let's see. So when we have a normal rhythm, what will happen? We do have a contraction, waiting, contraction, waiting. That's a normal rhythm, okay? What will happen when we do have an extra beat? That's a normal. And now, waiting, waiting, waiting. What will happen when we do have a tachycardia? Okay, that's fine. So the heart is contracting and relaxing. So we do have a systole and we do have a diastole. And as you see here, that's a possibility when we do have a rate that is fast, there is no waiting period between the contraction. So when the diastole is ending, immediately the systole is starting. That's called flutter. However, when you do have a much faster, let's see, electrical impulse formation, there is no way that it can relax or can contract because the muscle, let's see, mechanically, it cannot be contracted, it cannot relax, and that's called fibrillation. Okay? Did you understand?
Yes.
Yes.
And
yes.
of course, depending on, let's see, the impulse formation center, we can talk about we can talk about, this is the base of the origin, we can talk about sinus origin impulse formation abnormalities and non-sinus formation abnormalities. The sinus impulse formation abnormality is called nomotopic impulse formation. Why? The other one is called heterotopic impulse formation. The sinus or the nomotopic originated from the sinus. We can have, let's see, sinus premature beat. We can have sinus arrest. We can have sinus tachycardia. We can have sinus bradycardia. We can have physiological arrhythmia, sinus arrhythmia. So these are the all things that can originate from the sinus. So as we discussed, you remember that we had premature beat, only an early coming beat that comes earlier. We can have, let's see, every second beat is a premature beat. So we can have a bigemini. We can have a, for example, couplet or triplets or anything. So these things all can come from the sinus or from other areas. Another one, not from the sinus, atrium, AV, I think that's junctional, or ventricle, anything. We can have premature beat, we can have paroxysmal atrial tachycardia, multifocal atrial tachycardia, flutter, fibrillation. From the junction, almost everything except there is no way that we can have flutter or fibrillation from the nodal tissues. So there is no flutter, for example, from the sinus or fibrillation from the sinus, neither from the junction. Ventricle, similar to the atrium, anything can come. Okay, this is what we are going to discuss. How can we judge, first of all, coming earlier or later, whether it is a premature beat or not, or what kind of active arrhythmia we do have. And next one, we have to specify the localization, the origin of this impulse formation. Okay, now let's see. Let's start with the sinus premature beat formation. Anybody has any kind of questions so far?
So, Dr. Sorry, what's exactly the difference between paroxysmal tachycardia and flutter?
Say it again, please.
The difference between paroxysmal tachycardia and flutter?
Okay, paroxysmal tachycardia, when you do have, maybe I'm going to go back to this one. Paroxysmal tachycardia, when you do have contraction, relaxation, contraction, relaxation, contraction, relaxation. So you do have a diastolic time. When you do have a flutter, this is so fast that there is no way that when you finish the relaxation, immediately the contraction starting. So relatively, this means that fluttering the ventricle or the atrium. I will show you some picture when we are talking about the atrium flutter and the ventricular flutter, and you will understand the difference between the shape of the QRS complexes. Okay, a little bit you have to wait, not too much, a little bit only. Okay, let's talk about sinus premature beat. So that's the normal impulse formation as you see here. We do have, let's see, a P wave followed by QRS, T wave, P wave, and every PP interval or RR interval the same. What will happen when we do have a sinus premature beat? What happening? As you see here, we do have an early coming P wave, and this P wave is identical with the other P wave because it's originated from the same area. It should not be different within one lead. Okay, so far is good. Oh, yes?
Yes, yes.
Good. And another very important one that you should remember, the compensatory pause in sinus premature beat is identical with a PP, normal PP interval. So it's meaning that you are going to discharge the nodal tissue earlier. However, when you do have the slow current that normally is coming inside, let's see the sodium coming inside the nodal tissue, the slope is identical. So in the next, that should be the same. Only we have an early coming beat, but the next one, it should be the same because everything is not altered, only somehow you made an earlier impulse formation. Next one, when we, similarly to this premature beat, but we do have much more early coming sinus beat, and this is a regular one. This is what we call sinus tachycardia. Very simple one. You do have a sinus P wave, and the rate is faster than 100. However, it cannot be infinitive. So if everybody has a maximum of the sinus impulse formation, and usually is going to depend on the age. Do you remember what you learned in physiology? So you can calculate it. How much can be, let's see, the rate of the sinus? Who can tell me? Nobody remembers.
Which rate?
Yeah, what can be the maximum sinus impulse formation rate? Much more.
Isn't it like 200 minus your age?
210 minus the age, exactly. Exactly, maybe a little bit plus minus 10, doesn't matter. So relatively, if you are younger one, you can have a maximum rate is close to the 200. However, when you are older one, there is no way that you can speed up your heart rate too much. So my rate is maximum around 150, 160 or so as a sinus rate. Yours, for example, you are 20s, you can go up to 190, 180, close to 200. And when you want to exercise, you know that you at least 80% or 90% as so how long you have to keep, let's see, this high tachycardic period. This is how you have this aerobic, let's see, exercise. Now, so this is, however, if I do have, for example, a rate of 200 or 220, for sure is not a sinus. If I do have a P wave in front of the R waves, so possible that's an atrial paroxysmal tachycardia, if it starts suddenly, or a sustained atrial tachycardia. Could you follow me?
Yes.
Yes, sir.
Okay. Now let's go. Another thing that you can read, yeah, that can be normal or can be abnormal depending on what the problem is, and you have to evaluate, let's see, this tachycardia depending on the patient. Okay, now let's go on, and another one. This is a sinus tachycardia, very nice. You can see that the RR interval is less than 3. Axis, how much the axis is? 1 is positive, AVF is positive, normal. After which is the biggest one? Lead number 2. So this is around 60 degrees, a little bit closer to lead number 1. So I would say 50 degrees, because if you had 60, lead number 2 exactly in the middle between 1 and 3. And if you do have exactly in the middle, that reflection to lead number 1 and lead number 3 should be equal. But because you are having higher one, lead number 1, this is why the axis is a little bit closer to lead number 1. Could you follow me?
Yes.
Almost, okay. Now, let's see another thing that is called sinus arrest. That's a normal one. That's a normal. And what the sinus arrest means? Oops. When the sinus is not going to fire when it should fire. Okay. Exactly this interval, this absence is right here, exactly twice as long as the normal PP interval. Now, these things, it's almost impossible to be distinguished between the conduction abnormality when we do have, for example, a sinus block. So because there is no sign of the sinus activity on the ECG, what you do see only the atrial contraction. This cannot be, for example, sinus arrest cannot be distinguished from the sinus, let's see, conduction abnormality. This is what we are going to discuss on the next seminar. So when you do have only one is going to be out. Now, another problem can be here that if you have, for example, the rate of 60, okay? If you do have a missing beat, how long would be the rate here? Anybody?
30.
30. What is the problem with rate of 30?
120.
It's way too low.
It's too low, and the junction is going to fire because we do have at least 3 levels of impulse formation. The fastest one is the sinus, slower one, AV, the junction, and the slowest one, the ventricle. This is how we survive during the evolution. Now, the sinus is around 60 to 100, as I said, 180, 160. AV junction has a rate of 40 to 60, and the ventricle 25 to 30. So if the lower center can fire, it's going to fire. So that can happen, for example, here. Oops, see? An escape beat is firing here. And this escape beat should come from a lower, let's see, nodal tissue. For example, from the junction. Okay? So that can happen. Yes?
Sorry, sir. Does it always look like a negative?
No. We are going to discuss. No, but I draw here and I will explain why it's negative, but maybe you won't see anything. You won't see any P wave. That can happen. Okay, good. Now, sinus bradycardia, it's very similar, but the rate is slower than 60. That's it. Can be normal, can be pathological one. That's it. Okay. As you see here, rhythmic, very good. And the rate, how many? 1, 2, 3, 4, 5, 6, almost 7. 300 divided by the 7, well, it's close to, how much is 28?
40, close to 40.
40, okay, close to 40, good. Axis, 1 positive. AVF is equiphasic, 0, good. All right, sinus arrhythmias. Now we are talking about an irregular sinus arrhythmia or regular sinus arrhythmias. There are 2 major problems can occur. This is one is physiological or respiratory sinus arrhythmia. When we do have a, let's see, rhythmically altered vagal tone. So when we inspire, we do have tachycardia, or let's see the PPP interval getting closer. And during expiration, when the vagal tone increases, we have bradycardic period. You can test it if you feel your pulse and you take a very deep breath and after exhale it, and you will see how this all things can be seen. Another one usually in elderly people that can be non-respiratory, so it's not depending on the respiration. These 2 kind of sinus arrhythmias can be. Now, and other things that is it's a bad situation. It's called sick sinus syndrome when the sinus is sick. Usually what we do have, that's a tachycardic, bradycardic period. So it means that we do have bradycardia alternated with tachycardia. Sometimes the sinus impulse formation is stopped, so sinus arrest. We can have a block as well when the P suddenly disappears. So I would summarize that we do have an arrhythmia absoluta. So the RR intervals are chaotic, but we do have P waves. So we do have normal sinus P wave. So the 6 sinus syndromes can be associated with paroxysmal tachycardias, atrial flutter fibrillation, and AV nodal tachycardias or tachyarrhythmias, usually ischemic heart diseases or drugs or cardiomyopathy or amyloidosis or myocarditis. And as you see here, how does it look like? Well, we do have a completely, as you see here, oops, no, go back. What we do have here, we do have here that's completely arrhythmic, but you do have P waves. But sometimes the P is missing, so we have sinus arrest as well. So that's a 6 sinus syndrome. You should remember that arrhythmia absoluta with sinus P wave. So you should memorize this. Now let's go and let's start to discuss the heterotopic impulse formations. And this is first the atrium that we are talking about. So far, everything is clear with the sinus or a nomotopic impulse formation?
Yes.
Yes.
Okay, if you want, more or less it's fine. You can revise again the video, you can speed up if you wish, so fine. But this is regularly. So first of all, you know that how is coming in time and what is the origin of this impulse, and this is how you specify it. Now the next one is the atrial premature beat or atrial axis. Well, it meaning that we do have a P waves that comes earlier, but this P's is not, the morphology is not the same as a sinus P wave, all right? So that means, and usually this is undercompensated. Let's look at, it can come from only one area, but not from the sinus. It's meaning that when you do have this early coming P waves, okay, let's look at, okay, as you see here, this P morphology is not the same as another P's. This P is originated from the sinus. This P is not from the sinus, so that's from the atrium. How do we know that from the atrium? Because that's a P that's located in front of the QRS complex. So the impulse is propagated from the atrium to the ventricle. This is how we know. That if you do have the same kind of other bizarre shaped P wave, only one type of bizarre shaped P wave you have, that means unifocal atrial premature contraction. But that's a possibility that not only one area in the atrium is triggered, but more. And that meaning that these extra P waves, the morphology is be different from each other. And that is called multifocal atrial premature contractions. And that can be, if you do have two at the same time, that can be, how do we call as, or, okay, couplets or triplets, or salves, or can be, if you speed up, no, later on I will show you, but now let's go to this one. Okay, let's look at, is this rhythmic?
Sorry, Professor, a question.
Yes.
How can there be these beats in the atria if the sinus isn't functioning? Where's the electrical, how is it starting if the sinus is not functioning?
Look, the sinus is going to fire with a rate of, let's say, 60. Okay. Now, if you have an early coming beat that comes, for example, at the rate of 70 beats, so it's coming earlier. What it means that two possibilities. One, it can discharge the sinus, or mostly it's not going to discharge the sinus, but the sinus, when it fires, the impulse cannot activate the atrium because the atrium in the refractor period. Okay. So the sinus is discharged and it should fill up again and hit again. This is why we call that undercompensated, the premature beat. Could you understand?
Yes, thank you.
Okay, now here, for example, let's look at, here we do have arrhythmias. Very nicely, you can see arrhythmias. We can see P waves. Yes, we do see P waves. However, if these P's are not identical, see? Okay, maybe this 1 and 2. Let's look at, this is coming earlier, okay? And it looks like almost the same, but if you go down, for example, in AVL, you can see the big difference between this P wave. So for sure, because it's come earlier, that's an atrial premature beat, okay? That's again a normal sinus beat. Oops, it's another one early coming beat. And again, let's see, P is almost not very similarly to this. So that's an atrial premature beat. Oh, that's another premature beat atrial one here. So that's a couplet because two premature beat follows each other. And you see that the P is not the same as a sinus P. Okay. It's understandable?
Yes.
Yeah.
Good. Now let's move on. There is another thing that is called the wandering pacemaker. This wandering pacemaker is usually rhythmically coming, and rhythmically from the atrium, it's going from the sinus to the, let's see, the AV, from the sinus to the AV. So the sinus to the AV, and the P wave, the morphology, it's varies from the sinus to the AV. And that's rhythmically coming and coming and going. Well, what can be the answer for this one? I have no idea what generating, but sometimes it happening, possible some kind of oxygenation abnormality that affecting the atrium. That can cause the wandering pacemaker activity. It's not too common so. Another thing, so far we discussed only one beat, or we had maybe 2 beats. But what will happen when we do have a suddenly starting arrhythmias, tachycardias, as we call this a paroxysmal atrial tachycardia? How do we know that? Well, as you see here, maybe I'll enlarge it. So we do have a normal sinus beats, and after, look at that, look at that, look at that. We still have P wave, but that P is not the same as a sinus P wave. And because it's suddenly starting or suddenly ending, that is called a atrial paroxysmal tachycardias. Okay, now that can come from one focus, and that's a monofocal, that's a paroxysmal tachycardia. That's rhythmic but faster. Rhythmic but faster. Or can be coming from different part of the atrium. As you see here, we do have different morphologies of this P wave, extra P wave. That's arrhythmic, is not rhythmic at all, with different P waves. And that's the multifocal atrial tachycardia, or MAT, PAT and MAT. So here, do you remember what I said about 6 sinus syndrome? Arrhythmia absoluta with sinus P waves. That's a 6 sinus syndrome. Here, we do have arrhythmia absoluta with different P waves. And that's the multifocal atrial tachycardia. Okay, so we do have 2 arrhythmia absolutas. First, with sinus P wave, that's a 6 sinus syndrome. With different P waves, that means we do have a multifocal atrial tachycardia. Okay. For example, here, very nicely, you can see that, for example, these P's, when we do have this extra, that's the morphology is different from the other P's. So this is what we have at multifocal atrial tachycardia. It's understandable?
Yes.
Yes.
Good.
Just a question to make sure that I understood.
Yes.
So different morphology of the P wave means necessarily that the pulse didn't came from the SA node?
No. The different P wave means it's coming from the atrium, but not from the sinus. Okay. Normally, every impulse coming from the sinus. So every P should be the same. What we said, round shape, symmetric one. Let's say the length about 2.5 millimeters, the height is about 2.5 millimeters. That's a normal sinus rhythm, because the atrium is, let's say, depolarized or contracted in a synchronized manner. However, when you do have an extra, let's say, origin beat, that P won't be symmetric. That's be a different one from this sinus. Okay?
Yes, thank you.
You're welcome. Now, the method of the, let's see, the rate of the atrial impulse formation. Now, if we have more than 260, between 260 and 300, as you see here, what I mentioned, that contracting, relaxing, there is almost no way to have a little rest between the relaxation and the contraction. This is what we call as a flutter. As you do see here in a flutter, see, that's the P wave, but it's not a P wave. This is called the SAW waves, or it's called flutter waves, or that means F waves. Okay, so these are the F waves. And of course, because the rate is around 260 to 300, it can be proportionally conducted. So maybe every, let's see how many we have. 1, 2, 3, 4, 1. Okay, so 4 to 1 conduction that we do have. So every fourth F waves followed by the QRS complex. So this makes it regular, but it can be irregular as well when relatively randomly conducted, but mostly a flutter is regular rate. And you do see this very nice big F waves or sow waves, looks like as a sow, let's say the teeth of the sow. Now, organic heart failure or WPW syndrome, later on we are going to discuss the WPW syndrome as well. This can cause, for example, flutter or ischemic, let's see, heart diseases again. Very nicely can be seen these F waves in lead number 2 or V1. V1 is very close to the atrium. This is why you do see very nicely there. See? Very nice. That's a sow wave. See? This is how it looks like. If you do see this, very easy to diagnose because the atrial rate is very fast. It's around almost 300 or a little bit less than 300. And every 4th beat is conducted. So that's an Atria Flutter.
And there's no T wave?
Well, you can have T waves. I'm not saying that you don't have T waves. You have T waves. However, these T waves can be negative or exactly inside the sow waves. See, for example, here in lead number 1, you can see the T waves. That's a T wave. Yeah, the T wave is there. You always have to have T waves. If you do have QRS, you have to have T waves. There's no way that the repolarization is missing, okay? However, it can be hidden inside sow waves, F waves, okay?
Yes.
So usually these ECGs record it simultaneously. This is the 3-channel, let's see, ECG, but you can have 6 channels ECG or 12 channels ECG that's recording at the same time. And you can look at, for example, the all leads, how let's see the T wave and P waves and everything looks like in all leads. That's very helpful, for example, if you go through. Now let's see the atrial fibrillation. That's irregular, completely irregular, okay? Absolute arrhythmia, and there is no P wave. There is no P wave. The atrium has a multiple impulse formation center and a chaotic impulse formation. The atrium is shivering. There's no way that mechanical contraction can be, and the rate of this electrical impulse in the atrium is ranging from 300 to 600 per minute. Very, very fast. Very, very fast. And if you look at the tracing, sometimes you can see some fibrillatory waves. However, never ever look for these fibrillatory waves, because usually to avoid muscle movements and any kind of noise, high frequency noise, or from the electric outlet noise, they are going to apply a high pass filter on the ECG. And this high pass filter makes it a linear baseline. There is no wave. This is why you should diagnose atrial fibrillation based on arrhythmia absoluta and no P wave. Do you remember these 3 things, what we said so far? Arrhythmia absoluta with sinus P wave. What was it? 6 sinus syndrome. Arrhythmia absoluta with different morphology of the P waves.
Multifocal atrial
impulse formation of tachycardias. And if you have arrhythmia absoluta without P wave, that makes it
atrial fibrillation.
Atrial fibrillation.
Very good. So if somebody wakes you up midnight, you say immediately atrial fibrillation. Absolute arrhythmia, no P wave, atrial fibrillation. It's very simple. But when you're looking at tracing, looks like you are unable to diagnose it. Now here, what you can see here, we do see that we do have arrhythmia absoluta. Okay, this is let's say the rhythm strip. Okay, and there is no P wave. Yeah, you can see some fibrillatory wave, but sometimes you can see some noise. Okay, some noise. What the noise means? The noise means that how can you differentiate between the noise and the fibrillatory waves? Okay. Yes, not say it, say it.
You look at the wave shape.
Okay, and what the difference is? I don't know whether I can draw it or not. That's be the problem right here. No, I turn off, let's see, the drawing pattern, but maybe I want to have, possible. Okay, maybe I can draw it. Okay, let's see. This, oops, yeah, I cannot use this one. How can I use the freelance drawing pattern? Ah, that's it, maybe. Okay, so let's see. That's a P wave, okay? That's a P wave, that's a QRS. Yes, that's a QRS and that's a T wave. Okay, when you have a noise, what will happen? You do have a noisy background, a noisy P wave, a QRS complex, and a noisy T wave, yes? This be the noise. However, when you do have an atrial fibrillation, what you have, there is no P wave. You don't see this P wave. Only you'd have a fibrillatory wave, okay? This is how you can distinguish. So if you do see some fibrillatory waves and P wave, it's not atrial fibrillation. That's a noise. And the noise can be seen on the top of the T waves and the top of the P wave as well. All right?
Yes.
Good. Junctional. Now we are reaching the junction, the AV junction. The AV junction is located exactly between the atrium and the ventricle. Okay? So if you do have an impulse that is originated in the AV node in the junction, that can propagate toward the atrium or toward the ventricle. However, is depending on the time, whether the impulse first activates the atrium or the ventricle. We can have three different morphologies. Let's see. What will happen when the impulse activates the atrium first and later on the ventricle? We do have, as you see, a P wave. But let's see, what about the P wave? Because we activated the atrium exactly the opposite way, the P be inverted. In lead number 2, we do have a negative P in front of the QRS complex. And we do have a positive in AVR because AVR is looking at the right side of the atrium. So that's be positive in front of the QRS. Could you follow me?
Yes.
Okay. However, when you activate the atrium and the ventricle at the same time, oops, the P wave is inside the QRS, so you do not see any P wave. Or first you activate the ventricle and later on the atrium, you do have a P that after the QRS complex and of course be inverted because the opposite way is activated. So there are the three different situations that can happen when you do have a junctional beat or junctional impulse formation. All right. Now, what can cause, let's see, the junctional rhythm? First of all, if the sinus is slowing down, or if you do have an AV block, and when the junction can fire by their own. Okay, this is the possibilities. Now let's see what kind of junctional abnormality we can have. As you see here, we can have premature beat. We can have paroxysmal tachycardia. We can have escape beat or escape rhythm or junctional acceleration. I'm going to talk about later what the acceleration is. Let's see the premature beat. What is the premature beat? Well, the premature beat means that early coming beat. As you see here, okay, that's a sinus, sinus, sinus. That's a negative. The same kind of QRS complex, but this P came from the AV junction because every, how many? Let's see, 1, 2, 3, 4. 1, 2, 3, 4. Every fourth beat is a junctional premature beat. This is called junctional quadrigemini. Clear?
Yes.
Yes.
Good. Now, the junctional escape rhythm. The junctional escape rhythm, when we do not have any, let's see, beat coming from the atrium or is not conducted, after the AV node is going to fire. But because the impulse made by the AV node, the ventricle, let's say ventricle, is reached through the his and the Purkinje fibers and the bundles and the right and the left bundle branches. So the QRS complex has a normal morphology. However, we are missing the P wave, or we do have negative P waves, so the inverted P waves, and the rate is slower. Look at the rate, 35 to 60. Okay, let's look at this. It's rhythmic? Yes, it's rhythmic. Do we see any P wave? We don't. And the rate is very slow, it's around 30. So that's a junctional escape rhythm. Okay? Very similarly to the atrium, we can have paroxysmal junctional tachycardia. If we do have more than 3 beats, junctional beats, and that's suddenly starting, and very common one. That's very, very common supraventricular tachycardias, the paroxysmal junctional tachycardias. Now, how can we judge whether this is a junctional tachycardia? Very simple. The patient will know it. They can stop the tachycardia by applying carotid massage, increasing the vagal tone, because the vagal tone is altering the AV conduction, and that's this re-entry phenomenon that the paroxysmal tachycardia is mechanism based on, that is stopped. Okay, so this is how we can do. And plus, the QRS complex is narrow, 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 narrow. That's very important. See? Very fast, more than 300. This means tachycardia. Well, we don't see the beginning or the end, but that's a paroxysmal one. And here you can see, for example, that's a negative, so that's a junctional rhythm. Okay? Now, let's go on. Well, now that's a junctional acceleration. What the junctional acceleration means? Normally, the rate of the junction is 35 to 60. However, if you do have a junctional escape rate that is faster than 60, but less than 100, this is what we call junctional acceleration. So this is not a tachycardia, it's still in the normal rate, it's less than 100. However, because it's originated from the junction, a lower center that should have a much slower rate, that means for accelerated, but it's not tachycardic. This is what we call acceleration. It can be junctional acceleration or can be ventricular acceleration later on, okay? Look at, for example, here, it's close to 100, but it's less than 100, but we do have, see, it's a negative piece behind the QRS complex. So that's a junctional acceleration. Let's see the last one. The last one that we are going to talk about, that's a ventricular impulse formation abnormalities. We can have premature beat, paroxysmal tachycardia, flutter, fibrillation, escape beat, escape rhythm, and acceleration. Now, how can we distinguish between a ventricular premature beat and the supraventricular premature beat? Here you can see very nicely at the bottom here. As we do have a normal sinus beat, atrium is activated and the ventricle activated symmetrically through the bundles, okay, through the Purkinje fibers, so with a symmetric manner. When we do have a ventricular beat, ventricular premature beat, or any kind of ventricular beat, the ventricle cannot be activated through the normal fibers, is activated through the muscle-to-muscle phenomenon. Because the muscle-to-muscle conduction is slower, this is why the width of the QRS complex is wider than 0.1 second. Here is little than 0.5 second, wider than 0. Plus, the T wave is exactly the opposite to the main deflection of the QRS complex. If you had a positive R waves in the depolarization, you do have a negative repolarization wave. If you do have a negative, let's see, depolarization, the repolarization will be positive and wide. Okay, this is, I think you can see very nicely that that's QRS is not the same as the normal. Okay. Okay, let's see. That's a normal. Okay, this is what we know. And oops, looks like we do have a ventricle beat. Very similarly what I said. That's QRS is wide and the T is inverted. If this premature ventricle beat has the same morphology, that's unifocal. If we do have different morphology for this premature beat, that's called multifocal ventricle premature beats. Yes? More or less. And we do have every second beat is a ventricle premature beat, ventricle bigeminy, period. Every fourth one, ventricle quadrigeminy. And these are the couplets, ventricle couplets and ventricle triplets or salves. But you do see the ventricle beat is wider and the T is inverted. This is the common, very typical phenomenon of the ventricle beat. Paroxysmal ventricular tachycardia, again, starting suddenly. The rate is around 140 to 200, starts suddenly and cease suddenly. Carotid massage does not do anything at all. But another problem, if we do have an R on T phenomenon, have you heard about it in physiology? When the R wave is exactly on the top of the previous T wave, and that can trigger ventricular fibrillation. Okay, because that's the, let's see, the end part of the T wave or the repolarization is very vulnerable, and that can cause this situation. Okay. All right, here you can see the suddenly starting ventricle paroxysmal tachycardia. Now, idioventricle or accelerated, very similar. We do have a ventricle impulse formation, but the rate is not as a, let's see, 20 to 40, but it's around 70 to 80 in the normal rate. But these are ventricle complexes. And usually it can be stopped if you have applied a pacemaker with a higher rate, and that will stop immediately this ventricle, idioventricle tachycardia or ventricle rhythm. Usually this is an increased automacy. Usually the patient has a center that firing faster. What they can burn it, for example, if the patient is disturbed by this situation, this is how it's going to be cured. Flutter, very similar as an atrial one. That's only one problem, that is the ventricle happening. So there is no way, very small time for relaxation, but there is no gap between the contraction and relaxation. So the heart relatively doesn't get, or the coronary doesn't get a nice oxygen supply in the diastolic period. This is why the patient cannot tolerate too long this flutter, ventricular flutter. It looks like it's a sinus wave, but a very big amplitude. All right, that's a ventricular flutter. When we had, let's see, the Atria Flutter, if you can remember what we had, I go back to this point. Okay, look at here. See, this is what we have at an Atria Flutter. We do have normal QRS complexes. Okay, we do have a discrete, narrow QRS complexes. But when we do have a ventricular flutter, what we do have there's nothing, there's no P wave, not at all. Only what you can see, this is sinus wave, the ventricle. All right. Now, let's see, what about ventricular fibrillation? The ventricular fibrillation comes when we do have, for example, a very fast coming impulse formation, very fast impulse formation that comes from the ventricle. I'm going to share the sound of my computer, but I think there is no sound at all for here. Okay, this is what you can see. So that impulse from that can be seen as a ventricle, but these complexes, they are not the same. It's not the same as a flutter. They're different one. Okay. All right, go back to here. Good. Ventricular fibrillation, it's a deadly situation because the cardiac output is 0. So the patient losing consciousness, and only one way, if some kind of shock or some maybe by mechanically or electrically, you can discharge the heart. And if you are lucky or the patient is lucky, the sinus activity is going to wake up early, and after the normal impulse is going to be coming back. Now, ventricular fibrillation is very commonly happening if the patient has myocardial MI. But ion, for example, that can ion disturb, that can cause, let's see, ventricular fibrillation as well. Another thing, this is that other type, and usually this is the beginning of the ventricular fibrillation, but usually it's going to be caused by, for example, the long QT interval in hypocalcemia or ion channel abnormalities. That's a torsal de point tachycardia, when it's meaning that an axis, a main electrical axis, is changing revolution to revolution. Okay, so this is what we can see in the case of a torsal de point tachycardia. Somebody, I cannot see, let's see, the chat is right here. Yes, 200, what do you mean 200? I don't know what, maybe he said a little bit earlier, this 200, this sound.
For the sinus.
So yeah, but we were discussing the sinus. Okay, thank you. Okay, that was long time ago and didn't watch it. So this is how, for example, the torsal de point tachycardia looks like. It looks like is a, well, every time the axis of the main depolarization axis of the ventricle is changing. And it's coming back. And you do have a little wider, narrow situations. Now, that's very parasystolia. Now, parasystolia is a little bit more difficult to understand. Basically, it means that we do have another center in the ventricle that somehow is insulated from the normal depolarization, and it has the own impulse formation capability. It looks like that some kind of ventricle cell is taking over. It has some own impulse formation abnormalities. Now, what you do have that when this kind of extra center activated, and if the surrounding ventricle is in a refractor period, there is not getting the impulse at all. However, when the impulse is propagated to the ventricle, that can fire, it can be seen. That is going to be depend on the rate of the heart. If you have a faster rate, the chance to have this parasystolia is less. However, if you do have a slower rate, now this center can fire and can be proportional, let's see, in the length of this extra beat to each other. It can be, if you say this X, that can be twice as much, so 2X. This is the how you can, let's see, diagnose the parasystolia. But I think this kind of paroxystolia won't be here, so you won't get any kind of ECG. If you be a cardiologist, you can deal with this parasystolia later on. Okay. I'm not going to talk about this ICD or units. If you watch, let's see the videos, you can see it. Only one thing that I'm going to mention about this impulse or extra pacemakers, when we do have, maybe I do have, see, when we do have a little teeny tiny trigger in front of the white Q arrest, that's a ventricular pacemaker. If you do have these spikes in the beginning of the P wave, that's an atria pacemaker. And this pacemaker can be placed in the atrium and the ventricle and can be somehow sense the activity of the ventricle and can be directed by this. And this maybe sometimes is fire, sometimes it doesn't fire. And you can read about the nomenclature of this pacemaker. And for example, here, the dual chamber pacemaker, if you go there, oops, this is sometimes if you don't need it because we have a normal propagation of the P wave to the QRS complex. However, if you do have a bigger gap because the sinus doesn't fire, it's pacing the atrium, but because the conduction to the ventricle is correct, there is no need for another pacemaker activity. Sometimes this
Hello?
We cannot hear it as well.
He froze, didn't he?
Yeah, you're not alone.
Okay.
Probably.
start recording and sharing. Okay, good. So these kind of intraventricular devices, that's very useful and very widely used today. So if you look at the videos, you will see several types of it that can be used, for example, to defibrillate the patient. If the patient start to develop, for example, ventricular fibrillation or atrial fibrillation, this pacemaker can be, or device can be activated. Or another things, if somehow the heart is not able to generate impulse, that can place the pacemaker inside the ventricle. These are the ventricle pacemakers. And as you see here, we do have a little spikes in front of the QRS complex. This is the ventricular pacemakers. And if you do have a P wave started with this spike, we do have an atria pacemaker. Now, these pacemakers can be placed in both. It can be placed into the atrium and into the ventricle. As you see here, in a normal situation, when we have a normal sinus P wave conducted, the ventricle is activated, there is no need for the pacemaker. So the pacemaker is sensing the activity of the atrium and activity of the ventricle. When it's not needed, it's not going to fire. However, if you have no activity of the atrium, the pacemaker, what is set to the certain rate, is start to fire immediately and activate the atrium. And the impulse normally goes to the ventricle, so the ventricle activation be normal. There's no need for the ventricle pacemaker activity. However, it can happen that the atrium is firing, however, the conduction is too delayed and the ventricle is not activated in time, so the ventricle pacemaker is firing. And some other both firing, and that can lead, let's see, to the heart. Heart is contracting the heart. Today, we do have pacemakers that relatively, for example, when we do have an intraventricular conduction abnormalities, right or left bundle branch blocks, they can synchronize the ventricle activity, and especially that can cause a symmetric contraction, can normalize or get to normal to the cardiac output. So these are the role of these intraventricular devices, and this is how they use it. For example, to stop the fibrillation, or lead, let's see, the normal beats or synchronize the chambers. Okay, this is what I wanted to say. That's it, no more. Let's see.